consultant in our center. Our talk today will be regarding minimally invasive surgical AVR. My outlines will be regarding history of surgical AVR, patient selection and high-risk group, minimal invasive AVR versus conventional AVR, surgical techniques, and a brief regarding minimal invasive AVR versus TAVI, and my references. So, and start. Surgical aortic valve replacement amount for the second most common cardiac surgical procedure performed worldwide. Their indication has been mainly represented by symptomatic severe aortic valve stenosis. It is the golden standard for treatment of severe aortic stenosis and regurgitation for the last 35 years. And the most common cause of aortic stenosis is the calcific degeneration of anatomically normal aortic valve, which becomes interestingly common in the seventh decade of life. And since the mid-1990s, cardiac surgery has shown progressive and increasingly interest toward the development of minimal invasive and minimal access technique. Significantly demanding learning curves for the team and technical challenging for the operating surgeons. And the traditional cardiac surgery community remains concerned about the need of time-consuming and often technically demanding additional training for these approaches. So regarding patient selection, patients' morphological features such as chest size and chest wall abnormalities are carefully assessed and matched to both lateral and posterior anterior chest X-rays. It's absolutely contraindicated and uniquely represented by presence of important chest wall deformities such as pectus type or vertebral spine deformities, and in case of severe obesity. In large patients with uncommonly large anterior-posterior chest dimensions also represent technical challenges. In those cases, it's unpredictable variation from the normal internal anatomy can be responsible for an excessive distance and tickling angle between the surgical incision and the location of the aortic valve plane. So in cases of previous coronary surgery, the presence of patent lima to LAD coronary artery does not represent a contraindication, since the operation can be performed with the least moderate hypothermia and by delivering a regular dose of cardioplegia without the need of lima mobilization and clamping. And the need of coronary artery bypass grafting remains a limitation for a minimal access approach, and no target coronary artery can be appropriately visualized or exposed. But as an alternative in these cases, hybrid approach could be considered, which combines a single or double vessel PCI with a stent prior to the minimal invasive approach. So in high-risk patients, this means that those patients who have significantly morbid comorbidity and or undergo procedures that are associated with increased morbidity and mortality risk, such as elderly patient with LV systolic dysfunction, redo patient, and patient with COPD or pulmonary hypertension, and chronic kidney disease patient. So for minimal invasive AVR versus conventional AVR, studies that have limited data showed no significant difference in mortality rate between the minimal invasive and conventional AVR. For minimal access AVR, it potentially offers several advantages to the patient, but none to the surgeon, who requires some specific time-consuming training to perform a significantly large number of procedures in order to become as familiar as to those procedures that he or she has widely used sternotomy approach. Advantages for minimal approaches are cosmetically acceptable result, less bleeding, therefore less transfusions are needed. decrease tissue damage, fast post-operative recovery and rehabilitation, as well as shorter ICU stay and hospital stay, decrease both cross-clamp arrhythmias incidence and lower incidence for respiratory failure. Some studies also showed no difference between minimal invasive and conventional AVR regarding CKMB release and the incidence of delirium and stroke. Disadvantages for minimal invasive access is it's more technically demanding, longer operating times, and difficult de-airing process. This is how conventional median sternotomy versus minimal invasive. Here it's showing the upper limited sternotomy. So we'll come across the surgical techniques. Since the 1996, many minimal access approaches have been explored, and many terms have been used, such as mini sternotomy, hemisternotomy, upper sternotomy, and partial or limited sternotomy. These are the most common approaches: limited upper sternotomy approach, transverse sternotomy, right parasternal approach, and right anterior mini thoracotomy. So first, the most usually utilized is the limited upper sternotomy approach. In the left, we'll see the inverted T incision, and on the right is the J incision. So for the limited upper sternotomy, it was initially described by Gundry in 1998. It can be divided into 3 groups according to the anatomical criteria. There is upper, middle, and lower. Upper presented the inverted T shape, V shape, or J shape. Middle with the C shape or H shape, and lower with inverted L shape or T shape. So for the upper limited sternotomy, it's probably for the similarities shared with the full sternotomy, it has become the most frequently chosen for minimal invasive AVR. In several clinical series reported, it has been shown that the J approach for minimal access is as safer and effective as a conventional sternotomy approach, and at present it represents the gold standard minimal invasive approach for AVR. In adult patients, the skin incision can be limited 6 to 8 centimeter in length, starting at the Louis, the angle of Louis, and continue longitudinally over the middle of the sternum. It's in the original description, the sternum is divided in reverse T fashion. This can be achieved with a redo oscillating saw with a narrow plate. The sternal incision is completed at the left or right transversely into the intercostal space chosen. It's advisable to enter to the fourth intercostal space in order to allow more generous exposure to the patient with severe emphysema, or when chest X-ray shows that the heart lies transversely into the diaphragm. So this is as demonstration. So in brief, regarding the cardiopulmonary bypass circuit, we'll use the standard for arterial cannulation, straight wire enforced aortic cannula. And for venous, we'll use double stage venous cannulation, as one advantage of the upper limited sternotomy approach is the ability to perform central cannulation via the right atrial appendage, which allows good venous drainage without the need of vacuum assisted drainage. For cardioplegia cannula, can use standard with the cannula for direct ostial cardioplegia. And for avoiding the air emboli, we use the CO2, float the operative field, and prolonged venting through the aortic root and LV vents. So in brief for the process, the patient is prepped as usual as in the conventional sternotomy, with the preparation of both groin areas. Anesthesia is induced as standard with the intubation with single lumen tube, Intraoperative transesophageal echo is mandatory in all cases with aortic valve surgery. The patient is hibernized, and umbilical tape can be placed around the aorta to allow some traction to apply to choose a higher position for aortic cannula. And after the cross clamp of the aorta, which can be achieved with the conventional right angle aortic cross clamp without disturbing the working field, cardioplegia is delivered into the aortic root in case of aortic stenosis or regurgitation with no more than moderate. Transesophageal echocardiogram can be important to assess the LV dilatation while the delivery of cardioplegic solution. Regarding retrograde cardioplegia, a few published reports highlighted the risk of atrial perforation. Therefore, it's advisable to avoid this technique and limit cardioplegia delivery to the aortic root and direct into the coronary ostium. After the commission of cardiopulmonary bypass, LV venting can be achieved via the right upper pulmonary vein, which is safely reachable only once the heart is decompressed on the bypass, or uncommonly via the left atrial appendage or pulmonary artery venting can easily be performed as well. Oblique aortotomy towards the middle part of non-coronary sinus of Valsalva in case of stented aortic valve is used. This can easily be and safely be extended in case of aortic root enlargement if required. 4O Brulin sutures are used to pull each side of the aortotomy laterally in order to expose the aortic valve without the need of additional tractions. So additional doses of cardioplegia can be delivered directly into the coronary ostium in regular 30 minutes intervals. Positioning 2-0 ethbond sutures can be deployed in each commissure in order to gently pull the aortic valve plane closer to the incision and further improve the valve exposure. Then the procedure is carried out as same as fashion of regular aortic valve replacement. So these are the steps. So then aortotomy is closed with running 4O Prolene in 1 or 2 layers. Cardiac de-airing starts while closing the aortotomy and positioning the patient in anti-Trendelenburg position to allow filling of LV apex with blood. Ascending aorta venting is started at completion of the aortotomy closure, and air evacuation is facilitated by manual ventilation and gentle heart filling under echo guidance. The pericardial retraction suture should be released before coming off bypass. Positioning of ventricular basing wires is difficult and hazardous if accomplished after the removal of aortic cross clamp with non-decompressed heart. So it's recommended to gently expose the RV free wall and position the epicardial temporal base wires while the heart is still cardioplegic and obviously decompressed. The chest drains replacement is externalized in cosmetically appropriate position underneath and laterally to the right nipple in male, while in submammary fold in female. The upper sternum is approximated with the sternal wires and ethmoid sternal suture transversely, which allow optimal stability of the sternum, which the lower sternum remains intact. So the advantages for the upper limited sternal axis is the excellent exposure of the great vessel, no need for special setup or equipment in the OR. The internal mammary arteries are not sacrificed and remain intact. The ability for central cannulation for both arterial and venous lines, and it's easily conversion to median sternotomy if required. The disadvantages for this approach is the limited or impossible retrograde cardioplegia administration and difficult de-airing. Tips and pitfalls for this approach is a small flexible cannula should be used to minimize the obstruction of the operative field. If the venous cannula are attached to cardiotomy suction in minus 80 millimeter mercury, a smaller cannula can be used with better venous drainage and preventing of airlock. So the second approach we have is transverse sternotomy. In brief, this minimal axis approach was originally used in the late 90s, but currently it's no longer utilized. It requires 10 to 12 centimeter skin incision, most commonly performed transversely above the sternum, which is usually swing at the level of the second or third intercostal spaces. The pericardium above the aorta can be opened longitudinally, and its edges are pulled up to improve the aortic root exposure. Sensor venous cannulation can be done with two-staged right atrial cannula. And for aortic cannulation, it's usually femoral. The exposure of the aortic valve, part of the ascending aorta and right atrium can be usually achieved. And the sternum is reapproximated by a figure of 8 or 2 separated sternal wires at the end of the procedure. The disadvantages of this approach is the conversion to a full longitudinal sternotomy, if required, will be difficult, and it will result in 4 sternal fragments, which even after careful closure would be responsible for increased sternal instability at the end of the procedure. For the further drawbacks of this approach is the need of transection of both internal memories artery at the level of the intercostal space entered, which would preclude their future utilization in case of the need of surgical revascularization. The third approach is the right parasternal approach. In brief, it was originally prescribed by Kasparov in 1996, and at present, its only historically value is it's no longer in use. It need an 8 to 10 centimeter skin incision, which extend from over the second or intercostal cartilage to the fifth. And the muscle plane is divided, and both third and fourth intercostal cartilage are excised. The disadvantages for this approach is the limitation of this approach has been consequent anterior chest wall instability, which can result in from the incision of the excision of the costal cartilage. The sacrifice of the right internal mammary artery and the need of femoral artery and venous cannulation make this approach less attractive. The aortic atherosclerosis makes the femoral artery cannulation and retrograde perfusion less than ideal compared to the direct ascending aortic cannulation. In case of poor exposure or the need of emergency conversion into a traditional sternotomy, it's not practical and more likely leave the patient with a chest wall potential instability and increase the rate of wound complication. The last approach we have is the right anterior mini thoracotomy. So regarding this approach, it's initially described by Penty in 1997 and then popularized by the New York University Medical Center of Surgeons since the late 90s. The surgical approach is uncommonly used at present. The patient is most commonly positioned in supine, and the entire chest and groin are ripped and ripped as conventional approach. And the right chest can be somehow elevated by the use of chest roll, inflating pressure bag underneath the right scapula. The skin incision can be limited to 6 to 8 centimeters, performed laterally to the sternum over the third intercostal space. The chest is entered mostly by the second or third intercostal space, which is opened, and gentle rib spreading can be achieved with a small thoracotomy spreader. So regarding this approach, femoral cannulation is most commonly required, while direct aortic cross-clamping and antegrade cardioplegia delivery are visible. The limitation of this approach are potentially limited exposure, since rib fracture has been avoided for the benefits of minimal invasive approach to be maintained. The conversion into median sternotomy would be less than practical and lead into larger degree of surgical trauma than predicted. And minimal access patients appear to have significantly shorter hospital stay, and higher proportion of them were sent directly home rather than rehabilitation. So at the end, we'll have a small comparison between minimal invasive AVR versus TAVI. So for minimal invasive AVR, the recent study have demonstrated that minimal AVR is a reliable technique, as safe as a standard sternotomy method. It's associated with improved certain post-operative outcome and very low rate of paravalvular leak and stance of 20 years valve durability. While in TAVI, it's more accepted for its non-inferior result to surgical AVR, and the recent FDA approved for high intermediate risk patient. The main concern still exists for paravalvular leak and for the valve long-term durability. And patients with moderate to severe aortic regurgitation have a significant greater mortality at 2 years compared to its overall mortality. And these are my references. Thank you. Any question?
Can you hear me, Nof?
Yes, Dr. Atizaz, I can hear you.
Yeah, good. It's a nice presentation. Good. I don't have a question. I just have a few comments. Just, I think most of you are the residents in this forum, and it's for your teaching.
Yes.
It's good to review it like that. First of all, part of it is my own, let's say, bias or experience, whatever you call it. Before you people go very enthusiastic about minimally invasive, you should learn how to do a conventional aortic valve replacement with a full sternotomy. I'm saying that because when you do quite a good number, you will realize what are the difficulties. Every patient is not suitable. Patient selection for minimally invasive is important, and becomes more important when you have a calcific aortic root. As you mentioned, some of them redos you are not the candidates. As you people are getting into a time period when the TAVI is becoming more popular, I think when you become practicing surgeons, you will see more of the redos which had previously a valve implanted. And the indications for TAVI as initially were high risk, now it is medium to low risk. I think they are taking over because actually they are the minimally invasive. Whatever incision we make is is invasive. So we are not minimally invasive. We are maybe trying to limit our invasiveness. But our limiting the invasiveness then is at the cost of the safety of the procedure and the completeness of the procedure. The minimally invasive procedures are a little bit more difficult, as you very rightly said. You need to retrain or train specifically for those. But before you go into that training, you have to train yourself how to do a conventional full sternotomy aortic valve replacement. The some of the approaches which you mentioned, like hemisternotomy and probably the right anterior mini thoracotomy, these are the one which give you a better cosmetic result, and I think uh, just patient satisfaction more I would say.
Yes.
It doesn't make it easier. uh, you have to practice, you have to develop your techniques, and then uh, remember that it's still, you may have problem with de-airing, you may have problem with control of bleeding. If you are having a problem, you might have to convert to a full sternotomy. So the benefits are, I'm not sure, to be honest with you. These are the approaches which people are using. I think some centers and some surgeons develop an expertise and they train more in that, and they produce good results. But most of us have tried and then given up because we did not persist. The technology of the cannulas and this is improving, but see, if you have a minimal invasive approach, you want to limit the size of the cannula, especially the venous cannulas, and then you have to put a lot of this minus 80 millimeter of mercury of the suction on the venous side is a high suction, and can be a cause uh, of air trapping in all the circuit. So this is my basically my comments on this minimally invasive approach, as the surgeons they call it. But it's good to know about it and see how the technology is taking us forward. Thank you.
Thank you, Doctor.
Thank you, Dr. Atizas.
Thank you, Doctora, for the presentation. I wasn't from the beginning in the presentation. Haitham Albar with you.
Yes, welcome, Dr. Haitham.
Yeah, regarding minimally invasive, of course, you all know I just finished, but I was
Dr. Haitham, I can't hear you anymore.
you see the data from Cleveland Clinic. Hello?
Yes, sorry, Dr. Haitham, I couldn't hear you.
Now you hear me?
Yes, now I hear you.
Yeah, if you can look for the data from the Cleveland Clinic, the minimally invasive is just an approach, but the
Yes.
operation is the same. Actually, for the mitral valve, it's easier because it's in front of you. The view for mitral, it is direct or via thoracoscopic, via camera. You can do it both way or robotic. And there is different levels. As Dr. Atizaz said, it's need a special training, a fellowship to do that, to know the pitfall, to know the step, everything, to prepare yourself. But very important point I want to more stress on it, as Dr. Atizaz said, is first of all, when you went to do minimally invasive, if you don't know how to do it conventional, they will not teach you how to do that. They will teach you the approach. So first you need to know how to do it conventional, then you can go to minimally invasive. Around the globe nowadays, it's all shifting the gear toward the minimally invasive, but it needs a team. It's not only the surgeon, it's a full team. It's a program consisting of the surgeon as a consultant, the anesthesia, the perfusionist, the nursing. Everybody needs to be trained to do minimally invasive or robotic surgery. At that point, if you also see the series from good centers like Cleveland Clinic and their data, it's the same. The safety is good. the mortality is the same. And in some patients, especially in minimally invasive AVR, there is small trials showing that in some certain patients, doing minimally invasive is better. In some patients, not all the patients, in form of decreasing morbidity on them, especially the blood transfusion and all that. But it's a program, and you need a special training on it, and a whole team. The most important is a program. Thank you.
Yes, thank you, Dr. Haitham.
I have a comment. Hello?
Yes, welcome, Dr. Farid.
Okay. So I disagree with Dr. Haitham about that everybody is doing, or the trend is going more for minimally invasive. Actually, the most common procedure nowadays is the TAVI.
TAVI, yes.
That's by far is the most common procedure, and comes after that is the SAVR, surgical AVR, and the minimal invasive constitute a minimal percentage. So it didn't catch up very well with everybody for some reason. Maybe it's the difficulty, maybe it's the equipment, the cost of things, I don't know. But so it's a nifty procedure. It, just like you said, it has some benefits to the patients in particular. And if you are going to specialize in that, there are some patients who would prefer not to go for the surgical procedure, but to go for the minimal invasive if the TAVI is not available for them. Thank you.
Thank you, Dr. Farid.
Totally agree with Dr. Farid. Regarding the TAVI, totally agree with him. Thank you, Dr. Farid.
Can I comment on this, please? This is Dr. Claudio.
Yes, please, Dr. Claudio. Okay.
Well, definitely minimal invasive surgery for aortic valve replacement and for single valve procedures is becoming more popular, and requires a commitment. Doesn't require any special skills for any trained surgeon, just requires a commitment. And in the last 2 years, Prince Sultan, we did this, and we commit to do any single surgery, any single valve surgery, minimal invasive, either mitral or aortic, with the zero mortality and very low grade of complications. The results of TAVI in the last randomized controlled trial in the low risk patient, you have to keep in mind that the average age. First of all, these were European or Western population, and the average age of the patient was 73. So it's definitely different. My message is you have to develop a sort of center indication for TAVI and for surgical AVR minimal invasive, meaning that if you have surgeons and if you have a young population, you have to adjust from the result of these randomized trials coming from the Western world and talking about and dealing with all their populations. Our population here and also in the rest of Asia and Africa and South America are much younger. And if you have in a center, you have surgeons who do minimal invasive, you should consider that before going for a TAVI in a low risk patient. That's my point. The high risk patient is a different issue. but in the low risk, definitely, you need to develop your own center considering your own results. Because still TAVI can have complications, and this is what the people usually don't perceive. But even TAVI have complications. That's it. Thank you.
Thank you for your comment, Dr. Claudio.
Nice presentation.
Thank you, sir.
Any other comments or questions for Dr. Nof? Thank you, Dr. Nof, for your presentation. Thank you, Dr. Atizaz and Dr. Claudio, Dr. Haitham, for your valuable comments, and Dr. Farid as well.
Thank you,
So as
Dr.
I said,
Thank you, everyone.
as I said, we are supposed to have a journal club today, but unfortunately the presenter apologized. So we'll meet back at 3 p.m. We'll have a TAVI presentation from a TAVI fellow from McMaster University. Thank you. Good afternoon, everyone, and welcome back to our academic activity. I would like to welcome Dr. Iqbal Jafar to our academic activity meeting. Dr. Jafar did his residency at McMaster University in cardiac surgery, and after that he started his TAVI fellowship. I believe he just finished that program. Dr. Iqbal humbly accepted our invitation, though it's early in Canada. So I would like to welcome him again and thank him for accepting the invitation. Dr. Iqbal, the mic is yours. You can start at any time. Thank you.
Thank you very much for the invitation, it's my pleasure to be here. It is early here. I think Fajr time just set in.
Yeah.
But that's okay. I'm here.
Thank you.
So I'd like to speak about TAVR from a surgeon's perspective. These are my disclosures, nothing relevant to this talk, but what I'd like to talk about is how we assess patients, how we do the procedure, some complications, and then a few words about training. So as Dr. Alkhalaf said, my training was primarily in cardiac surgery. I trained at McMaster. It's a 6-year program. And recently, the Royal College of Canada has switched to doing it as a competency-based program, and so that that can alter the timeline. After I finished my cardiac surgery training, I did a full year of structural and CT, which was basically primarily TAVR as well as CT. The interesting thing is that the program was originally designed for interventional fellows, and I was the first surgeon that went through that. So I basically was trained as an interventionalist, which has its pros and cons, and we can talk about that. So in terms of patient assessment, we know that patients who have severe aortic stenosis, who go into heart failure, they don't do as well as those who are treated. So initially there's a 50% drop in survival without AVR, and those curves stay on track with each other. From the Partner 1, which is the original partner trials, looking at transcatheter versus medical therapy in patients who are prohibitive risk for surgery or high risk for surgery, we see that the TAVR group, the mortality at 5 years was around 50%, and without TAVR or just medical therapy, the 5-year mortality is around 80%. Consequently, in the patients who are high risk for surgery, who received either TAVR or surgery in the other partner trial, their mortality at 5 years is high, but it's equal. So meaning that the treatment essentially, regardless of what it is, in high risk patients, sort of normalizes your curve. The way we used to think about TAVR, and subsequent trials have pushed this boundary more and more, is that we used to think about patients who were very old, had very low BMI, were very frail, they had LV dysfunction, they were low flow, low gradient AS, they had severe MR with mitral annular calcification, or pulmonary hypertension, or COPD, or they had no revascularization options, or they're end-stage renal failure or liver disease, cancer with limited lifespan, cognitive dysfunction, malnutrition, and then there were some technical issues. Now, in surgery, we know that these are the patients that always do worse, right? So, but some of these patients walk the line of futility, and some of these patients walk the line of high risk. Now, it just depends on which one of these factors that you have that ends up on which side of this line that makes them either doable for surgery or not. Now, we know that the patients who are all low risk are young age, bicuspid, because most of them are younger anyway, no coronary disease, good function, not a redo. Those are the sort of patients that we like to operate on. But these are the patients that also that TAVR is now coming after, as it were. I may use that sort of language to say that, but I don't think that it's an antagonistic sort of a relationship, and I'll explain that later. We still consider all of these factors in deciding how we choose TAVR patients or how we choose surgical AVR patients. And I think that as the field gets more and more robust in terms of our ability to understand who does well and who doesn't do well, some of these factors push people towards futility, and so we avoid doing those patients. This is an interesting classification system that's been developed by Philip Genero, who's from the US. So again, we think about severe AS as just the valve, but whereas in mitral disease, we think about the left atrium and the pulmonary vasculature. This is a way to kind of integrate the whole heart and the amount of damage that the AS has done to the heart to see how patients do. So, severe AS, no damage, and then you get LV damage, which is where you get increased LV mass, which is your concentric hypertrophy. You get diastolic dysfunction, and then you get a drop in your EF. And we know that these things are some of the earlier signs of severe AS. Then you start to get mitral regurgitation, moderate to severe MR, and then you get your AFib. As it progresses even more, you get pulmonary dysfunction because you get atrial fibrillation, then you get pulmonary hypertension, then you get right-sided issues, and then you get RV dilatation, and you get moderate to severe TR, and then you get the last stage, which is your moderate to severe RV dysfunction. Now, Genero looked at all these patients, okay, and then grouped them in these stages. And in this study, they found that there were approximately this number of patients that they were looking at. So about 50% had some evidence of stage 2 damage. Around 12% had minimal damage. Very low numbers had no damage at all, and some had very bad damage. And then he looked at what happens to them 1 year after aortic valve replacement. And it's no surprise that the worse stage you are, the worse you do, even 1 year after AVR. So I just want to let that soak in for a second. So thus far, if you don't treat severe AS, you have excess mortality. Medical therapy for severe AS results in excess mortality. Any intervention, SAVR or TAVR, for even high-risk patients is useful. And waiting until ventricular decompensation results in excess mortality. So what we're trying to get at really is that AS is a continuum of a disease, and some intervention, whether it's TAVR or SAVR, is useful, ideally earlier rather than later. So the Canadian Cardiovascular Society has this sort of position statement for how they decide on which patients, or help you decide on which patients would do better with which procedure. So in our clinic, and I'll talk about our clinic in a minute, but we consider all of these things, and there's another framework that's been introduced by the American Heart Association in their most recent valve guideline as well, which was present in the 2017 update, which talks about integrative factors in terms of organ dysfunction, as well as procedural complexity, frailty, and the Society of Thoracic Surgeons risk score. So these are all just different ways to think about how these patients are. So let's see. So risk of surgical mortality or morbidity greater than intermediate. Now, intermediate was defined in the partner trials as greater than 8%, as 4 to 8%. And so from the partner trials, as well as the Evolute high risk, the core valve high risk trials, we know that high risk patients do better with TAVR than they do with surgery. Advanced age, frailty, limited mobility, that favors TAVR. Small annulus requiring a small valve, that favors TAVR, unless you're willing to do a root enlargement. The argument around root enlargement is still ongoing. Longevity unlikely, minimum of 2 years. That's what we kind of talk about for TAVR. Mediastinal anatomy unfavorable for surgery. That's usually talking about radiation to the chest or previous surgery or thoracotomy, patent bypass grafts, or a hostile root. That also favors TAVR. And then we talk about aortic root anatomy unfavorable for TAVR. And that sort of refers to big annulus, risk of coronary obstruction, bulky calcification. That all favors surgery because you can deal with all that. Right bundle branch block is a particular issue for TAVR because there's a high risk of causing left bundle branch block, which then results in total AV block. Any non-femoral access for TAVR, the alternate access, always are more risk than femoral access. Bicuspid, because they've not actually been formally tested in any of the TAVR trials. The Sievert 0, which is the true bicuspid, is the hardest ones to deal with. Aortic insufficiency without stenosis, risk of coronary obstruction, concomitant conditions requiring surgery. So if you need AVR plus CABG, or you need replacement of your ascending aorta or anything like this, mitral valve, then those push towards surgery. Aortic aneurysm or dissection, and then endocarditis. So our clinic, we have an integrated aortic valve clinic. We work together, interventional cardiologists, surgeons, and a nurse practitioner. And we take all patients age 65 and above with severe symptomatic aortic stenosis. And we meet the patients and we do some planning. We do a planning CT plus or minus a coronary angiogram. We review the patients together, and then we decide TAVR, surgery, or medical treatment. And so the way that our clinic goes is the first visit is we get a referral, and then we assess the patients in this virtual visit. So we talk to the patients on the phone, we assess their symptoms, their functional status, their medical history, comorbidities, goals of care. And then we decide, essentially, is their aortic stenosis severe and they need treatment? And so we go with further workup. Or their aortic stenosis is not severe, or they don't want treatment, or it's not indicated. And certainly, you know, we meet patients who are 65 who say, I feel well, I don't feel anything. My doctor sent me here because of an echo or a murmur that they heard. And then we have patients who are, 95 and they don't move very much. And the last time they moved was to go for an echo and they found severe AS. So we see all sorts. And so the first phone call really helps us decide whether we're going to do some more investigations or not. So the second visit then, so the first visit is by the phone, so the patients don't have to leave their house. The second is an actual in-person visit. So the patients have a CT, an echo, and ECG on the same day. And then we review the investigations by ourselves. So in our group, we read the CTs ourselves. We don't have the radiologist read the CT. And we decide, is TAVR feasible? Is surgery feasible? And do they need cath? So the CT often lets you look at the coronaries. And so we look at high syntax score coronary artery disease. And if there is high syntax score coronary artery disease, or there's a story of angina, then we choose to do invasive angiography. Now, some groups always do invasive angiography before the procedure. We sometimes defer that to at the time of the procedure. Now, certainly if the patients are going for surgery, then we'll do invasive angiography before the procedure. At the same time, we meet the patient, we do a frailty assessment, we introduce the treatment to the patient, and then we talk about recommended treatment and the next steps. I find this a very powerful way to do things because when you talk to the patient on the phone, you get a lot of the history and such, but surgeons are very good at seeing patients from the end of the bed. And so seeing people as well as having all their investigations in front of you really is a powerful tool to assess patients very quickly and efficiently. So let's say that they're going to proceed for TAVR. They come to our cath lab on the day of their procedure. They have their procedure, which is done under conscious sedation. We do most of them percutaneous without cut down. We ambulate them early. We take care of them overnight in our cath lab. And 90% go home the next day. We send virtually every patient home unless they have a permanent pacemaker with ambulatory monitor, like a Holter monitor. And then we make sure we follow all the rhythm issues like that. In terms of follow-up, they send their monitor back. And if there's any issues on the monitor, that's monitored in almost real time by our electrophysiology group. The patients have a 4 to 6 week echocardiogram, and we review the investigations. And again, we do a virtual follow-up unless the patients want to see us because there's any issues. So just give you a quick example of how we go about things. So patient J is an 87-year-old male with exertional dyspnea. He's referred for NYHA class 2 symptoms and worsening echo showing severe AS. He has a history of hypertension and osteoarthritis. So this is his echocardiogram. It shows severe AS. His mean gradient's around 40, 39, with a Vmax that's around the severe range. It's around 3.7. So he's perhaps not quite severe. So what we do is we take this and we integrate this with the CT. So we do a CT calcium score, and the calcium score helps us tie break is what we call it. The calcium score above 2,000 in males is more than 85% specific for severe AS. The more you go above 2,000, the more specific it gets. And in females, it's above 1,200. So this guy's valve calcium score is around 3,000. So again, what we're looking here is, this is the aortic annulus. These 3 dots are part of the software, and they help you find the nadir of the valve, and then you do all your sizing measurements based on the nadir of the valve. We're looking at the calcification in the valve level, okay, and most of it's in the valve. Here's the coronary here, and you can see that there's no bulky calcium in the LVOT or in the roots or in the ascending aorta that would be of concern. We also look at the femorals. This guy has pristine femoral access. There's no significant tortuosity. There's no significant calcification. This stuff up here in his abdominal aorta is mild, and many people have that. And so that's not a concern. So we received the referral on Thursday, for example. The patient was consulted by phone the following Monday. He has an ECG, an echo, and a CT on Wednesday. And we do a brief physical exam and surgical assessment on Wednesday after the tests. And that's basically the way we think about how we think about patients, how we prep our patients, and how we assess our patients. Now, in terms of the conduct of the procedure, the conduct of every procedure is basically the same. So vascular access. So we do a fully percutaneous approach, which again allows for shorter case time as well as for early ambulation. So most of our access is on the right side for the big sheath, and then so our small access is on the left side. So we get arterial and venous access on the left side. We get arterial access and insert the big sheath, which is the valve sheath, on the right side. You then go up to the valve. You take your pictures that help you determine your angles, and you cross the valve. You then place the wire in the ventricle, and I'll show you this in the next image. Sometimes there's a predilation where you do just a aortic valvuloplasty, and then the next step is you implant the valve. Now, every procedure is essentially the same, but the complexity of each of these steps, increases based on the anatomy, based on the patient's body, et cetera, et cetera. A thin person, all of this stuff is fairly easy. A thin person with no calcification, this stuff is fairly easy. A larger person with deep vessels, lots of fat, that sort of thing, this becomes harder. Lots of calcification sometimes necessitates that you can't do it percutaneous, and so in those cases we do a elective cut down. So we go back to our first case example. This here is the big sheath. Okay, this is the valve sitting across the annulus. This is the wire that sits in the LV, and so you need to park this wire fairly deep in the LV apex. This wire is a transvenous pacing wire, which helps you control the rate during the procedure. So basically, we rapid pace and we deploy the valve. Now, this is a balloon expandable valve, and balloon expandable valves, the pacing run is between 5 to 10 seconds, and the deployment is very quick. In a self-expanding valve, the deployment is much slower, and the pacing run isn't so aggressive. In a balloon expandable valve, you need basically zero cardiac output while you deploy the valve so that it doesn't dislodge, whereas in a self-expanding valve, you don't need that. So I'll just slow it down and go back a little bit. So you start the pacing run, okay? You inject dye to ensure that your placement is optimal, okay? And then you start to inflate the valve there, okay? And you complete the inflation so that you get maximum inflation. The inflation of the balloon is volume controlled. So there's a preset volume, and all you have to do is inject the full volume into the valve, into the balloon, sorry, and everything is sized based on that. Now, because of the way we do assessments, this step is a very low cognitive step in terms of making any final decisions. Once you place the valve in this position, okay, you aren't making any decisions about sizing or anything like that. All you have to decide is that the placement is correct, and then you deploy the valve. The sizing, all of that decision making is done before we even get to this stage. And then any decisions after this is deployed in terms of whether this valve needs to be post-dilated, whether it needs to be, whether there is an option to post-dilate, all of those considerations are also made up front. So if we know that there's nodular calcium and that this valve may have a small leak or may not open, or it's in a bulky valve, in a bulky calcific valve and needs to be further expanded, all those decisions are made beforehand. So this guy has a successful TAVR, and everybody's happy. So let's talk about complications now. Should I stop and take questions, or should I keep going?
Maybe you can continue and take questions at the end.
Okay, no problem. No problem. Okay. So in terms of complications, I grouped complications into three categories. Now, periprocedural, acute, and chronic. Now, periprocedural is, as it sounds, right around the side of the procedure. So vascular injury, annular rupture, tamponade, complete AV block, and then renal injury. So vascular injury is obviously from access sites. We focus a lot on access sites. Every one of our punctures, either arterial or venous, are done under ultrasound. We have a low threshold to do a vascular ultrasound afterwards if we're not happy. And we always do a follow-up angiography after we close the vessels. With percutaneous approach, you do get more risk for vascular complications, but with cut down, you get more healing issues, and you can get seromas and that sort of thing. So when you control the vessel with a cut down, you have total control of the vessel, but you have an incision. When you do percutaneous, you have a higher risk of the closure devices failing and sometimes needing emergent cut down, but we find that to be a very low risk situation. Annular rupture. Annular rupture happens when you oversize a valve for the size of the annulus, or you have calcification. So we spend a lot of time with the CT making sizing decisions. Tamponade is usually from the wires. You cause cardiac perforation. I think in a year where we did around 250 cases, I think we had one tamponade, and it was from an RV pacing wire. AV block is sort of the bane of TAVR, and then renal injury from contrast. Now, typically these are low contrast studies. We give less than 150 cc's of contrast in most cases, but people with borderline renal function, we're even more cautious. Acutely, which is sort of in the first week to month, AV block, thrombosis on the valve, and we'll talk about that, endocarditis, as with any prosthetic valve, and then vascular issues. Sometimes these present as late after the procedure, where you get a pseudoaneurysm formation. And then chronic, AV block continues to be an issue. Valve thrombosis continues to be an issue. Endocarditis, and then structural valve degeneration as you extend past 7, 8, 10 years. So conduction abnormalities. So conduction abnormalities are multifactorial, and there are procedural factors, there are patient factors, and there are ECG factors. So in terms of the patient factors, increased age, female gender, decreased LV function, your LVOT diameter. Sometimes the LVOT is conical shaped like this, where the annulus is bigger than the LVOT. Sometimes it's upside down, where the LVOT is bigger than the annulus. And when the LVOT is like this, where it's smaller and the annulus is bigger, you size to the annulus, but that means that you put more stress on the LVOT, which can increase your risk for pacemaker because you're pushing on the left bundle. The length of the intraventricular septum, especially the membranous portion of it, and then mitral annular calcification as well. In terms of your implantation depth, if you do pre-dilatation, if you have a valve that's bigger than the annulus, if you oversize your valve more than 15 to 20% based on the annular size, that increases your risk for pacemaker. Patients with already existing conduction abnormalities, so especially right bundle branch block and atrial fibrillation, first or second degree AV block, left anterior hemiblock, bifascicular block, and a prolonged QRS. All of these sort of add up to increase your risk for pacemaker after TAVI. And so what happens if you get AV block? Well, you know, they stay overnight with the pacing wire in, they need ICU, you can't mobilize them, they need more consults from your EP colleagues, they need pacemakers, and then those come with complications. There is increased morbidity with the patients that need a pacemaker. You will obviously lengthen their hospital stay. They need follow-up and replacements of the pack and the leads. And then there's more pacemaker at late follow-up, rehospitalizations. There's potentially impact on LV function and potentially on mortality. So we know that TAVI has an increased risk for pacemaker, but and so it's not a benign issue, especially with this is the reason we do the monitor on discharge for all of our patients, because we worry about this. Hold on one second. So a lot of patients, not a lot, but around 10% of patients will develop a new left bundle branch block after TAVI. So there's a reduction in LV function, especially in low EF patients when you get a left bundle. Impaired recovery of the LV function and symptoms. Again, increased rehospitalizations, increased risk of pacemaker, but there's no impact on medium-term mortality, especially in high and extreme risk patients. So that's not been seen in the studies. So thrombosis. Because of the CT, there's been an increased appreciation that there is a phenomenon of subclinical leaflet thrombosis in bioprosthetic aortic valves. So the 4D CT, this blackness is your thrombus, and this phenomenon is called hypoattenuated leaflet thrombosis, HALT, H-A-L-T, and it started to be noticed when they were doing routine CTs on some of these TAVR valves, where the patients were completely asymptomatic. The other way this manifests is you get increased gradients at follow-up. So a month after the procedure, or a year after the procedure, or 6 months after the procedure, somebody does an echo on these patients, and all of a sudden their gradients are elevated. And so then you do a CT, and then this is the sort of picture that you get. So these are different valves, okay, and what they look like under fluoro and under plain CT, and then reconstruction. So your Sapien, which is the TAVR valve, Evolute, which is the other TAVR valve, Lotus, which is a TAVR valve, Portico, TAVR valve, Centera, TAVR valve, Symetis, TAVR valve, and then Perimount, which is a surgical valve, and Magnais, which is a surgical valve. And you can see that every one of these valves, all bioprosthetic valves, they all have this phenomenon potentially develop. Now, many of these are asymptomatic, and often we don't do CT on all these patients to check. So what is the incidence of this? Well, the incidence of it is potentially around 3%. That's been reported in this paper. It happens in lots of situations, but balloon expandable valves are a particular risk. Valve in valve, where you put in either a TAVR valve in a surgical valve, a self-expanding valve in a surgical valve, or a TAVR valve in a TAVR valve, or a balloon expandable valve in a surgical valve, and then using antiplatelet therapy alone. So whenever we have more material, so it's a valve in valve, we always anticoagulate with a vitamin K antagonist, usually warfarin. So what do we know about subclinical thrombosis? Well, we know that the 4D CT is more sensitive than transesophageal echo. It's usually early, but sometimes it can be late. It happens in all tissue valves. It happens more in TAVR valves than in surgical valves, and it happens more when you do valve in valve than when you do valve in native valve. Warfarin or NOAC or DOAC are preventative and therapeutic. Now, I would argue with the DOAC because the Galileo trial, which looked at rivaroxaban, didn't exactly prevent this. It did reduce the incidence of it, but didn't prevent it. Antiplatelet agents alone don't work. And if you stop anticoagulation, it can recur. So what we've been doing, and I've recently just started a clinic looking at these patients, and so I think we'll know more as time goes on, but what we do is when we have a patient who presents with increased gradients, we do a CT. We see if there's thrombosis or not. If there is thrombosis, we anticoagulate them with warfarin for 3 months. And then at the end of 3 months, we do an echo. If the echo gradients are back to baseline, then we suggest that the valve thrombosis is resolved and we stop the anticoagulation and we do another echo a month later. If the valve gradients are still elevated, then we persist with anticoagulation for another 3 months and then we do another echo after 3 months. And again, the same story. If the gradients are back to normal, we stop, and if they're not, we continue. We don't know whether this strategy works, but nobody really knows. When you have HALT, when you have subclinical thrombosis, there's no clear evidence of increased stroke or mortality, but we think that you can lead to early structural failure and potentially late restenosis, as well as the fact that you have elevated gradients, which mean that you don't really resolve your aortic stenosis issue. So we've had patients where the post-procedure gradient is 10, which is excellent. And then they come back a month later and their post-procedure gradient is 30 and they don't feel well. So they don't have any thrombosis, but their resolution, their LV mass regression, their improvement in ventricular function, all of that is impacted because they have this subclinical valve thrombosis. So let's talk about structural valve degeneration. This is one of the biggest criticisms of TAVI. Well, we don't know how long the valve will last. So let's review that. Now, we know that all tissue valves eventually will undergo structural valve degeneration. We know that the structural valve degeneration happens as a result of calcification on the leaflets and of tissue ingrowth. And it does look different in the type of valves you deal with. So this is a equine pericardium, which is the original core valve, basically used horse pericardium, whereas the sapien valve, the balloon expandable valve, used bovine pericardium, much along the surgical technology.
Valve 404.
So this is a valve test done in a accelerated manner. So this is a Magna Ease valve, which they do open and close tests. And you can see that the valve looks different, even though it's the same platform, the same technology. The surgical valve, the leaflets are sort of pristine looking. There's no folding of the leaflets, and the reason for that is we don't post dilate these valves in the operating room. They come to us like this, and we implant them like this. With this valve doesn't need to be crimped or anything like that. So it looks perfect because it's been designed to look perfect. Now with the TAVR valve, remember, this has to be crimped down where it's a fraction of its size so it can go through the sheath, and then it needs to be expanded. So there's a little bit of redundancy built into this. Now, the other reason for that is because a TAVR valve can be expanded beyond its nominal size. So in a 29 valve, the volume of the balloon is 33 mils, okay? You can expand this valve beyond that 33 mils by adding more volume. So if you have a larger annulus and you want to expand this valve even more, then you can add more volume to the balloon and expand it beyond that size. So you need some of this redundancy built into those leaflets so that it can accommodate that, so that the coaptation height is not completely splayed out like that. So, summary for this section. The need for a pacemaker impacts many aspects of a smooth procedure. There are several factors that contribute to the need for pacemaker, and some of those can be mitigated. So we will sometimes send patients for a prophylactic pacemaker, knowing that they have high-grade AV block and that they're going to need a pacemaker anyway. And so we have our EP colleagues see them before a TAVI procedure. They get a pacemaker, and then we do the procedure, and then it goes very smoothly because they can go home the next day. Valve thrombosis can occur acutely or late, but anticoagulation with a VKA can lead to resolution. And then structural valve degeneration is a phenomenon that impacts all bioprosthetic valves. In TAVR, the mechanisms of implantation and dilation may alter valve durability, but we're still seeing how that goes. Now, as we've started to do lower risk patients who are going to live longer, they may follow the same curve as patients who have a surgical aortic valve in their 60s or early 70s, who then live on into their 80s and 90s, where they're going to need another valve procedure. So a few words about training. And I wanted to focus on this because this is a group of surgeons or surgical residents. And so I want to give you my perspective on this. TAVR isn't going anywhere, and the role of TAVR will surely expand. Now, there's a trial ongoing right now, which is mimicking a surgical trial, where we're doing TAVR in patients who are asymptomatic, and that trial is called early TAVR. So even though the asymptomatic patients weren't tested in the original trials, I'm sure that there are patients who are asymptomatic or minimally symptomatic who are being done. We know none of the bicuspids were tested, but we know that we're doing bicuspid. Valve and valve was not included in any of the original TAVR trials. We're doing those. So the role of TAVR will expand. Cardiac surgeons, I think, have been very wise to be involved with TAVR from the outset. But I think that the importance of choosing the right intervention for the right patient is what should be paramount. Now, I find it very empowering to tell the patients that I can do either procedure. I can do a surgical AVR or I can do a TAVR. And I'm not really married to the approach. What I'm married to is the outcome. I think that the outcome is what's important. Now, if you have no coronary disease and you're otherwise well, and you could have either surgery or TAVR, we offer you both. And I've had patients choose surgery, and I've had patients choose TAVR. But who would want to argue with low procedural risk, going home the next day and feeling well within 3 days versus having a sternotomy and taking 6 to 8 weeks to feel well? It's a hard argument to make for patients. Technical assessment and suitability for the procedure is one of the most important things that we do. And we spend a lot of time looking at this and using technical factors as well as suitability in all of our decision making. The skills acquired during this sort of training are important for surgeons as well as interventionists. So the advantage of being a surgeon going into a TAVR program is that you understand 3D relations in the aortic root. And so the skill acquisition for you is to understand what it looks like on a two-dimensional surface under fluoro, for example. That took me a lot of time, but it's easier to go from 3D to 2D. If you understand it in 2D, now trying to understand it in 3D, that's more of a challenge for the interventionalist. The handling of wires, the interventionalists do that extremely well, and I don't even purport to think that I do that half as well as they do. But other things that we do is we're very good with vascular access and knowing when there's a problem and when to cut down. We also have started doing more percutaneous access in the operating room because of what we've learned from the TAVR. So there's sort of this back and forth engagement that happens. The heart team approach to care, I think that's one of the best aspects of all of this. In every guideline since around 2014, the heart team approach where you sit together and actually make the best decision for the patient in front of you, that's a class 1 indication in every guideline that I can think of. And it gives you an opportunity to display your strengths and talk about their strengths and see what you can do as a combined approach for the patient. And lastly, I'm a better doctor for having trained with people outside of my world. You spend all day long with surgeons, you think like a surgeon, and you understand what they say, they understand what you say. You don't really have to work hard to explain yourself. But when you work with people who don't think like you, who don't understand you all the time, and you don't understand them, then you have to work harder to explain things to each other, and that makes you better because you understand what issues they're coming at, and they understand what issues you're coming with. I also think more carefully about my patients and how to manage their issues in a broader manner. In surgery, we do we look at the patient, we think, oh, you're too frail for surgery, but through the TAVR program that I went through, I do much more comprehensive assessment of their functional status, of their cognitive status. I think more broadly about involving geriatricians, palliative care, et cetera, et cetera. So I think I take better care of my patients moving forward. And then again, I can offer better care because of the skills that I've learned and the cross-pollination that happens because of these regular interactions. I often get patients from the aortic valve clinic that need surgery. Now, all of these patients have had a CT scan. So I have now become an expert on reading these CT scans. I do my own sizing of the valve. So I rarely go into an operating room to do an aortic valve without a CT that's already been measured. I know what the aorta looks like. I know what the valve looks like. I know what the annulus looks like. I can tell you where I'm going to cut. I can tell you what valve size I'm going to have. And so, these sorts of things, again, make my life better. And these are skills that I've learned through TAVR that make my life better. So these are all the people that had a hand in my training that have supported me over the last several years. And so I want to thank them all. I want to thank you all for this invitation. I'm humbled by this invitation and happy to take your questions.
Thank you, Dr. Jafar, for this nice and thorough presentation. So I would like to open the floor for questions. I have a question of my own, but maybe you can start with the floor and then.
Anybody
Anyone has a question for Jafar, Dr.
Jafar? So if you allow me, this is Faisal, 7th year resident. So thank you, Dr. Jafar, for accepting the invitation and coming early morning in your time to give this presentation. I really enjoy it. My question will be more toward the training situation. So how is the situation in Canada? I mean, is there a lot of centers that offer TAVR training for surgical cardiac surgical graduate, or how is the situation there?
So that's a good question. When we last looked, there are programs that will say that they will train a surgeon. As to how many actually have, I'm not sure. There are programs across the country that have TAVR surgeons, at least 5 or 6, but every single program wants a TAVR surgeon. I just don't know whether they're all training TAVR surgeons in the same way that I've been trained. Many have been trained in the US, and they do it as part of a broader aortic training, that sort of thing. But to my knowledge, in Canada, there's not a program that trains the way that I got trained for surgeons, apart from mine. Anybody else?
So I have a question. How do you weigh the patient's preference in these clinics? So if patient, for example, wants TAVI and the group agreed to that he needs surgery.
Yes.
So how would you manage this situation?
So this happens all the time, because what happens is that the community cardiologist often will tell the patients, well, I'm going to refer you to the TAVI clinic, and they'll come with the expectation that they're going to get TAVI, and they are not technically suitable for TAVI. So we did this yesterday. There's a guy who was referred to a surgeon, and the surgeon said, well, why didn't you go get assessed, and we'll make a decision. And he said, well, I don't want surgery. So we often explain the rationale for how we make decisions. Both of us are there, both an interventional cardiologist and a surgeon are there to talk to the patients. I often will use the technical factors to explain to the patients why they're at high risk for TAVR, and why they would not be suitable for surgery. And the guy yesterday, for example, I showed him his CT, and I said, look, this bulky calcium is the reason that you can't have TAVR, because this is what the valve will look like when we deploy it, and this is the leak that will happen. And I think that many patients, when you speak very plainly about what their risks are, what their benefits are, they understand what you're talking about, and when you are very honest with that sort of an approach, I think that people accept. That guy is 86 and he accepted, because we helped him understand what we were thinking about and how we were thinking about it, and then we also showed him that his surgical risk wasn't that high. So that happens all the time. It's like patients who come for coronary angiography and think that they're going to get a stent, and then you have to talk to them about bypass surgery. They're never happy about it. But if you help them understand why what you're proposing is better for them, and that you're going to do it safely and how you're going to do it, I think most people understand that you don't come at these decisions lightly.
I have a question. Thank you, Dr. Jaffer, for your presentation and your time.
Thank you.
My question: which type of the valve you preferred, and any consideration regarding the selection of the type of the valve? Thank you.
So that's a good question. So I come from a center where we're almost 100% balloon expandable. We certainly do see a role for the self-expanding valve, and specifically in small annulus or in small valve-in-valve, the self-expanding valve is certainly a better option. The issues, I didn't want to really get into the technical issues around TAVI in terms of balloon expandable versus self-expandable in terms of coronary access, but the balloon expandable, because it sits lower and it sits shorter, coronary access, if you need an angiogram after the fact, is much easier than it is with the self-expanding valve, which sits much taller. So my bias is the balloon expandable valve, and certainly the balloon expandable valve is the more popular valve across the world. But the self-expanding valve certainly does have a role, especially in small annulus and in small valve in valve.
Thank you.
Any other question?
Can I ask a question?
Sure.
There's 40 people here. Are you guys from all over the country?
Yeah, this platform is for all the cardiac surgery residents that are involved in the local Saudi cardiac surgery program. So all over the country from central area. Yeah.
It's a 6-year training program?
It's 7 years. 7 years.
7 years, okay.
Yeah. I believe we have Dr. Khogir, who's the head of the scientific committee, the program. Dr. Farid, any comment from your side?
Well, thank you very much, Jafar. I think this was a very nice presentation, and it certainly will shed light for our graduates this year to think about this fellowship training. We do have some centers here which do the TAVI, and unfortunately most of our programs are run by cardiologists, but the surgeons do have a role in some of these centers. Yes. And just like we said, having a team will be the best for the patient outcome. I would like to invite you for future interaction for anything that can help our residency programs. Just like you heard, I'm the head of the scientific committee now, but even in the future, I think anybody else would welcome any collaboration if you can lend us any of your time. Thank you very much.
Absolutely. I would love to. I've trained with so many Saudis over the years, and I've trained with people from all over the Gulf over the years, and even those sorts of interactions have been very enriching, and I have friends all over the place through the Gulf that have promised me invitations. I'm still waiting.
Okay, we'll make sure that this word will go around. Thank you very much again.
Thank you very much. Take care.
I'd like again to thank you, Dr. Jafar, for your time. And by this, we'll conclude our session. Thank you very much.
Thank you very much. Take care.